Welcome, everyone, and a special welcome to you, Beth. Just reviewing your intro has been inspiring, and it's so great to have someone who centers the lives and experiences of the folks that you touch and affect through your work in this space. It is a celebration of those lives, and it's really an honor to be able to share this time with you. I will have to leave a little early, so I think someone else will be facilitating Q&A, but I'm happy to be here to make this connection and to present you to our community. Dr. Beth Meyerson is a professor in the Department of Family and Community Medicine at the University of Arizona College of Medicine, Tucson. She's focused on policy and systems change to improve pharmacy and medical practice in order to reduce opioid overdose and bloodborne illness and infection among people who use drugs. Beth's expertise is community-based participatory action research, my favorite thing in the world, implementation science, including all stages of hybrid studies, and translational science from policy to practice. Really valuable, really valued rather. Dr. Meyerson is also director of the Harm Reduction Research Lab with the National Transdisciplinary Faculty from 8 universities and 1 community-based organization. Beth is also the policy director for the Comprehensive Center for Pain and Addiction, which addresses chronic pain and substance use disorder through clinical care, research, education, and policy. Finally, Dr. Meyerson is faculty of the LGBTQ Plus Institute at the University of Arizona. Just firing on all cylinders there. Beth is a self-described pracademic. I love that, meaning that she came to full-time academic work after a career in public health practice, in roles as founding CEO of an international policy consultancy focused on sexual health, and as the Missouri State AIDS and STD Director and convener of the Governor's Council on AIDS. With well over 80 papers and countless monographs and policy briefs published, Beth has several funded studies, and her current work is funded by NIDA and the Vitalist Health Foundation, and serves as a mentor to so many fellows and mid-career faculty from universities throughout and across the U.S. And importantly, Beth co-chairs the promotion and tenure committee. So you want people like this making decisions about our careers. So that's great. And is a member of our department's committee. Research liaison for the Arizona MOUD ECHO, statewide MOUD learning community. And also is the research liaison for the Arizona Opioid Treatment Coalition, a statewide coalition of methadone clinics, so many other spaces, and the work is going to speak for itself. Beth lives in Tucson, Arizona with her wife of 35 years, Jill, their newest dog, Vessie, and they often see their son, Jake, who is in his first year of college. Beth, welcome.
I am thrilled to be here. Thank you, Corey. I really appreciate it. You can blame Katie Bailey if you don't like the presentation. But I promise I will not speak long. I promise, because no one should have to suffer that. But so please interrupt though in chat, and somebody just shout out if I don't see the chat, if there's question somebody asked. So I'm thrilled to be with you today for sure, tell you a little bit about our NIDA study and provide a little bit of information about methadone and MOUD. I don't use the term MAT because that's medication assisted treatment, as if whatever else is in there is the thing. And actually, I think the molecule is a lot of that miracle. And the people we work with prefer medication for opioid use disorder. But if I use an acronym that you're like, what is that? You need to just shout out, and it's no trouble at all. So national numbers highlight why we must continue to conduct substantive and innovative research to advance methadone treatment specifically. One person dies every 6.4 minutes in the US from an opioid overdose. 6.1 million people live with opioid use disorder. And ours is kind of a mercurial drug supply where people don't know what's in the drugs they're taking. They believe what they're buying. They're like, oh, I want a little bit of this, a little of that. And it's a crapshoot every time. And so it's really unsafe. 1 in 5 people have access to medication for opioid use disorder if they want it, and we don't even know about the quality of that. And in my state, it's been everything from Bible reading for 6 hours to what we would consider standard of care. So even all of that, access to mood treatment can reduce opioid overdose by 60%. So it's a game changer for us. So, really, just three take homes for you today. I'll talk a little about our lab and our PEEPs and our orientation of CBPAR so that you can understand kind of how we get this work done. I'll talk a little bit about how we're applying the REAIM framework and the value of our fidelity measurement to skinny down what we're doing so that it's precise, because one size doesn't fit all. And I think we all appreciate that. And that is the case with interventions. So, the Harm Reduction Research Lab was formally established in 2018. Our work is translational, as Corey mentioned. There are two through lines of inquiry not mentioned here. One is the theory and measurement of engagement, community engagement in science and its impact, micro, meso, macro. And the other is the measurement of harm reduction practice to improve intervention precision. So it's not just about the activities like, oh, syringe access, da, da. What is it? And I think that's for national discussion, and I look forward to seeing that go. The lab faculty hail from 8 universities and 1 community-based organization across the US. We're transdisciplinary. So it isn't like we all just bring disciplines to the table. We fight amongst our disciplines and have a kind of microculture of creativity. So public health policy, system science, sociology, pharmacy, nursing, medicine, implementation science, sex work, drug use, treatment experience, traumatology, psychology, biostatistics, sociology. My colleague Jen De La Rosa, who's an expert, is a sociologist, and she's on this call to suffer through it. We develop also the pipeline of researchers with lived and living drug use experience, because I think it advances the science. And so, for example, the R33 that funds the work I'm talking about, in year 2, we will have a 2-year postdoc for someone with lived experience focused on implementation science and CBPAR orientation. And I'm serious about that. And I don't care what the Trump administration is doing, but this is really what we have to put forward and create space for. All right. So we do our work with guidance from a statewide drug policy research and advocacy board called DPRAB. And we center our work on the people who do it because we're implementation scientists, and the people who experience that work because we're equity focused. And together we set the agenda, the research agenda that we do as a laboratory. The DPRAB also plans the research together, sometimes wants to carry it out with us, as well as paid researchers, that we decide what stuff means together. I'll talk about a few innovations because of their expertise. We decide what's important about the findings, how to translate it to policy and practice. And I just want you to be clear, don't be mistaken. This is not an advisory group. This is like a practice community-based research network. And that is what this is. And we are fortunate to have it. It's co-chaired by Christina Arredondo, who is a mood provider for Pascua Yaqui Nations and also an FQHC in town, and Arlene Mahoney, who was faculty of our lab, who runs Sonoran Southwest Recovery Alliance and also a sex workers union in the Phoenix area. Okay, so for those who really are new to this, I just want to make a quick stop to say, hey, I did say that mood access to medication for opioid disorders can reduce opioid overdoses by 60%. Mood is methadone, a full opioid agonist, and buprenorphine, a partial agonist. We're talking about the receptor here. I'm not going to discuss naltrexone because I don't see the data that it's effective. They each, though, methadone and buprenorphine, act differently. They are preferred differently. They are socialized differently. They are politicized differently, as evidenced by our bifurcated regulatory structures around each. So, for example, in the US, today, you can be prescribed buprenorphine for opioid use disorder from a prescriber with a narcotic license, such as a primary care provider. This is dispensed as pharmacies. If you are prescribed methadone for pain, well, you can get it the same way. But if you're being treated for opioid use disorder with methadone, the only permitted providers are among the approximately 2,000 opioid treatment programs, formerly methadone clinics. So it's different. It's not the same. So even with the promise of methadone treatment, our patients are voting with their feet and they're leaving treatment at rates that are so different. And it's because it's where you live. It's where you live. About the rules of treatment, the range reflects location differences in state policies, for example, in companies and their policies around how things are delivered and the financial incentives of that delivery. And frankly, it is a frenetic environment. 100 people on average have to come to the clinic, every clinic daily to get their treatment. Imagine 100 people in a clinic in 4 hours. People tell me they don't even know how long they're having to be there just so they can have their medication observed as they ingest it. It's a really draconian system, and we need to really normalize it, which is that we in this country. So we're witnessing a changing system of mood treatment in the US here, initiated by a policy experiment during COVID with unprecedented allowance in treatment accommodations that we would consider to be more patient-centered. So telehealth, multi-day dosing, which is, you heard me say, some people, and actually we just completed a national study, which I'm not going to discuss here. Over half of the people on methadone across the US have to come in daily for somebody to watch them drink their liquid methadone. But telehealth allows for less of that, if you will. Multi-day dosing means I can take more than a day's dose home with me. Think prescription. Relaxation of other draconian practices, prescriber autonomy to individuate treatment. So Beth gets the treatment that's right for Beth, not that everyone else is getting just because that's the way it's delivered. These changes were expanded and sustained through a federal final rule that you see right there. That was published in February of 2024. As I say, some state policies have followed suit, like Arizona's, where I am. Some have not, and corporate policy is adjusting. This all remains in flux. And so as scientists of implementation and, based in communities that we care about, the challenge is first to understand what is happening to implement these changes. Well, how the hell do we measure that? That's a good question. And if they make a difference, if the implementation of these things actually makes a difference, these are all the things that we are studying here. Okay, so what I'm talking about is that individuated care, meeting people where they are, patient-driven treatment, use of telehealth, reduction in requirements to be treated for medication. If I don't want counseling from my clinic, or patient education or group education, can I still receive my methadone? Yes. And that's good, because counseling, as one of my former PhD students found, could be ranging from anything from Beth, you paid your bill, to what we would call cognitive behavioral therapy light. So, we're not giving the high quality to everybody in every place. So you should be able to decide for yourself. Okay. During COVID, we studied the implementation of these changes. So in Arizona, we did a bifocal study. The DPRAB said we want to learn from patient experiences. That's on the left side. We want to learn from providers. So patients said and providers said about the same thing. These are all open access publications, by the way. We do not publish anything but open access, because we think that as a practice-based community, why would I expect anyone to get it if they had a paywall or to know about it? So it's not just an equity thing, but it's also a practice-based. I want everyone to know about what we learned and what we need to learn and what we messed up and all of that stuff. Okay. We essentially found that patients did not experience the changes. Prescribers did not implement them, especially in methadone clinics. So we conducted a national study of opioid treatment programs for a snapshot of the implementation of the final rule. We just finished this and found very similar results. The focus was methadone there. This will be published soon. Okay, so you probably recognize the CFR. Y'all probably likes this framework too. We use it because it's really accessible. Our policy partners get it, meaning, oh, I get the outer setting, I get the inner setting, I get these other characteristics. So federal policy recommendations do have some influence, but they're not the only influence. And so as the DPRAB was discussing the COVID studies, the findings we did in COVID, people on methadone were saying, I'm traumatized in my experience. Is there some kind of a transference of trauma? Something's going on. And then prescribers were saying, there's this cultural aspect of clinics, that this kind of inculcation of stigma-soaked recovery culture, like everybody's got to do it. Recovery is a full-time job, or I went through it, you got to go through it, or something like that. So we were kind of touching on these sociological, psychological kinds of components that actually seem to be something we wanted to investigate. And so we are. We're thinking about the things on the left side of this screen and how they might interact, how that changes the adoption of practice change. So the new good ideas, the more patient-centered things, whether it's evidence-based and what the patient outcomes are. So this is how we're conceptualizing the interaction of these intersetting factors as we seek to understand how they influence this stuff. And at the individual staff characteristics level, we began to investigate staff trauma as an interrupter of change recognition and practice change adoption. Now, you might know, again, reminding, opioid treatment programs can be frenetic places, average of 100 patients coming through a clinic with just a few hours. So there's some organizational characteristics that seem to matter. So our team followed the theory of the impact of vicarious work-related trauma and post-traumatic stress symptoms on the adoption of treatment innovation, or the recognition of the need for change due to the cognitive changes that occur when trauma is not addressed. So this is based on several studies in domestic violence, nursing, substance use disorder, demonstrating that the quality of care and treatment quality is diminished as a result of vicarious trauma and untreated post-traumatic stress symptoms, PTSS. So the two papers cited at the top right report findings from our study among opioid treatment programs in Arizona. And here's what we learned, just as a quick take home. 63% of the staff had clinically significant post-traumatic stress symptoms. And what I mean by that is they needed trauma treatment. 63% of them. 73% endorsed vicarious trauma symptoms. And we also documented a patient to provider pipeline, which we kind of knew in substance use disorder treatment. Like, if I've had the experience, I kind of want to give back. I kind of want to be involved. Sometimes it's a economic thing. Nobody hires me because I had incarceration experience because of the war on drugs. But then we saw this kind of role cycling in everything but the clinical medical roles. So I've had a job, I've had everything from security guard to front desk to counselor to this to that. We don't know if that matters or what it does, but here's what I want to show you. I give a talk called Kryptonite and Superpower. What we learned is that personal substance use experience among OTP staff was their superpower. Those who had lived drug experience, more compassion, satisfaction with the work and the patients, workplace safety. This is a safe place to be. I'm not afraid of my patients, not afraid of each other. I don't have to be rules following. I can encounter change. Burnout levels were lower. People with vicarious work-related symptoms had more burnout, but when you put them together, when Beth has substance use experience and vicarious trauma symptoms, it is kryptonite. Her compassion satisfaction plummets, workplace safety plummets, her depression is higher. And so this is what really is where we focused our work when we thought about our national study that I'm going to talk about right now. So you saw the COVID data, and you saw and I just shared with you the vicarious trauma and trauma symptoms data. Together, that formed the basis for our NIDA grant. And we pulled 4 types of interventions together that were evidence-based. But here's the thing. We based it, pulled them all together, but each area had to still be refined. And we felt, as implementation scientists with CBPAR orientation, that we needed to refine it with people who are on methadone and providers of methadone. And so, I'm just a geek in the room with a bunch of tools. That's it. So our praxis of engagement and the value of safety that we've built over the years with our DPRAB drove the development of an innovative structure that we call a helical structure of trauma-informed community engagement. It's actually the vehicle for our collaborative development of MPACT components. So you view the slide from the left to the right, and you can see the workflow and the handoff between 2 groups that safely functioned separately from one another, but handed off each other's work to iteratively develop it. And that's really important. It honored trauma histories and safer spaces while still building on one another's work. And so this is an innovation of community engagement for sure. It's under review with our MPACT protocol, but I wanted to share it with you because our research team didn't develop the components. The people who are experiencing them and actually considering to adopt them, like staff, are the ones who developed it. Okay, so the outcome is what you see here. 4 experimental components of this particular program: an accredited training, clinic self-assessment, reflective supervision, which if you're a clinical person, you'll know this is a guided modeling quality staff-patient interaction. We wanted to offer it to anybody, counseling case managers and peer staff, to help up their game but it's a lot of self-care, boundary stuff. It's really good stuff. And most people have to pay for it. So we thought, well, let's do this for our colleagues, and also some staff wellness, trauma education, and a link to an anonymous assessment online for post-traumatic stress symptoms and vicarious trauma, curated based on their scores to particular levels of messaging, including link to their treatment for trauma. So so that's kind of where MPACT became a thing. And our study is essentially, hang on just a second here. Okay. So what you see is the R61 component, which is just finishing up right now. This is an intervention development and pilot testing component among 100 patients and 18 staff at 2 Arizona opioid treatment program clinics. I'll talk about the re-aim and its application in a minute, but you can see it's got a development aim there, and it has an implementation, feasibility, acceptability, preliminary effect that will help us determine effect size, and the preliminary effect on methadone treatment retention, which we are measuring as the primary study outcome, increasing patient methadone treatment retention as time to first treatment interruption from study enrollment, active treatment at enrollment, which is day 0, day 30, 60, 90, and 120, continuous days in treatment during the study period. And then the secondary study outcomes include reductions in vicarious trauma and post-traumatic stress among enrolled treatment program staff, the ones who enroll in the study, although MPACT is open to everyone in the clinic, who are staff, I should say, and post-traumatic stress among enrolled patients. So phase 2 begins this fall, and it's a hybrid cluster randomized controlled study around, and I'm saying 40 clinics, 800 patients, and 50 staff, because that's what we're thinking before we really see what the effect size looks like and whether we need to adjust our trial sampling method. So what I want to do now, and I only have a couple more slides and we'll chat. So we applied the re-aim framework throughout our process of study development and implementation, and we'll report this at the time that we report our study findings. But in terms of reach, we're studying the number and proportion of clinics participating in the study over total invited, and that'll be an issue in the trial, not the pilot. The number and proportion of staff participating in the total, in the study total, and by clinic. So for instance, the pilot outcomes for our reach, we had 11 staff out of 25 total who could participate and enroll. And I should say enroll in the study. We're talking about study enrollment is reach, not intervention enrollment. The intervention of MPACT is available for every staff member of the 2 pilot clinics. We are studying MPACT through enrollment in our monthly surveys at this point with our pilot, but surveys every 11 weeks over a 20-month period for our trial. So for the rural clinic, we have 5 of 7 staff are participating. That's 71% as study participants. Urban clinic, 6 of 18 staff are study enrolled. So 91 of 800 total patients enrolled in the study. So they're getting surveys as well to kind of comment about the level of care and the alliance that they feel, what they're observing in the clinic. They don't really know about MPACT at all. They're just telling us how their care is and has been changing during this course. In terms of adoption, that's where we're looking at the MPACT components, component exposure, and that's measured monthly through surveys, self-reported. The training completion, enrollment in the trainings, the completion of the trainings, reflective supervision. This is all about participation in that. And so we're really talking about percent of eligible staff that could do this and their degree of completion, meaning number of sessions. This is every other week. Wellness screener use, the participation in the clinic. We call it TICA, but it's trauma-informed clinic self-assessment. Did they do the anonymous survey that actually populates the data? Did they participate in the staff discussion about the findings? In terms of implementation, I'll talk about that in a minute, because that's really where the fidelity hits the road. Efficacy and effectiveness, we're talking about for staff, vicarious trauma, and we're measuring that with the vicarious trauma scale. Trauma symptoms is the PTSD checklist. Burnout and empowerment scales. Practice changes are reported in the survey. And then we use the abstinence, Capel-Horn's abstinence orientation scale. For patients, the effectiveness and efficacy is shown in their PTSD checklist, treatment retention that they're reporting to us, in treatment overdoses, which we didn't spend too much time with NIDA about this because they say they're high risk, high reward, but it's a lie. So we thought we're going to really follow what people on methadone talk about, which is they have to self-medicate often because they're either underdosed or they can't make it to the clinic due to draconian requirements. So they have to go to an unsafe drug supply to be their own doctor. So we're actually looking at this as well. And then changes in the provider behavior. So using the Kim Alliance scale, the patient empowerment scale, that's Bond scale, and some team-derived patient-centered practice scales. So those are the pieces. For implementation, we have a champion fidelity check-in meeting individually for clinics every other week, reported distribution by a calendar plan, distribution of materials, launching of materials. I compare champion reports to staff survey outcomes. This is how we know things. Participant reports from reflective supervision. And then I often evaluate by back-end data that we're pulling from website portals. But here's where the fidelity matters. This is where it really matters. Implementation is where we really found important data to guide the refinement of MPACT for the trial. One size does not fit all. And even though everybody loved the ideas they came up with, the fact of the matter is staff had a clear preference for the components of MPACT, and we're still studying this. So by the end of March, we'll know what really was this. To measure adoption at the clinic level, we looked at exposure, adoption, meaning uptake of things, and certainly through the champion meetings. And the plan here is not just to push through MPACT as if we made this dude, we are going to force this dude through trial too, because that's what we told NIH. I don't believe that. I think we learn as we go. That's what the 61 period is for. And we're going to skinny this down with really with the advice of people on methadone who are part of our DPRAB and informing this study, as well as key informant interviews that we're planning at the conclusion of the staggered pilot period. So the rural clinic ends at the end of February, their pilot period. The urban clinic ends in mid March. So we'll be conducting key informant interviews with the staff that might want to earn $60 for 60 minutes kind of thing, and really just talking to us about their preferences and what they recommend, because this is not about them. It's all about, hey, what do you think your colleagues across the country might like? So let's talk about what didn't work here. Let's talk about when the wheels fell off mile one and stuff like that. So my hope is that you've appreciated kind of what's gone into this intervention, how we baked the cake. That it was really a collective effort based on evidence that we developed over time. I hope you appreciate kind of our approach and application of some implementation science frameworks and the community practice-based engagement around MPACT and our kind of continuing learning environment that we're really striving to go for, so that we all kind of get a little smarter as part of the process. So I think I've talked really way too long, and I'm going to just stop right here and entertain questions.
Thank you, Beth. I know for these type of calls, we don't usually have the usual audience clap, but just know that there are probably people clapping for your presentation now, myself included.
Just don't say they have the clap. That'd be good.
So at this time, we're going to transition over to the Q&A section. So if anybody has any questions that you'd want to ask for the Q&A section, feel free to unmute yourselves and yeah, feel free to participate in the Q&A. You should be able to a question, and I do see that we have one already in the chat from Stephen. So I want to give Stephen a chance to ask their question directly, if you can. Stephen, are you still on the call with us? Well, I may just ask since maybe they're not able to unmute them. Oh, here we are.
So there are all sorts of new controls and limitations on research and that are being put in place by the new administration. And I'm worried about that interfering with your study.
So this voice sounds so familiar, and I think we know each other from eons ago in AIDS work. So I'm just going to say shout out to you. And I think we talked about this as a team. I think we're okay for now because we're not ticking any of their red flags. And also, I think that they might see it as medicine. It is. I mean, it's all these things, right? It's the improvement of medicine. And I think that so far, so good. But, the minute we step into any of the spaces that they've demonized, Steve, I think that's really where we'll get in trouble. But my hunch is, and what I said to my team is, let's just move forward and presume this is going to be okay. And just keep claiming this is what the science is saying, it's what we're learning. It's all about improved treatment. Everybody wants improved treatment. You don't force it, you want to offer it. And we know it can reduce opioid overdose. And I always hate to do this in the policy process because when I worked in HIV, the same thing was the case. I got to make an economic argument versus a humane life argument. And so I'm like, okay, here's what an overdose costs you. And if we can reduce that by 60%, y'all save some money. Even though versus we would say, we save some lives. So, I mean, so far, so good, fingers crossed.
Thank you for that question, Stephen. We do have Dr. Shantae Washington who has the raised hand. I believe she may have a question as well.
Yes, good afternoon, everyone. Mrs. Meyerson, thank you so very much for your valuable contributions to science and all your sacrifices, which we know when it comes to contributing to science and helping populations in need, it could be a lot of sacrifice. So thank you. So I'm the president and founder of Regional Impact Health Foundation, and we are currently working with police departments and hospitals to implement our mobile health crisis recovery unit. And we want to have the most optimal, effective strategies to be able to serve people that are unhoused, but also have traumatic experiences while we're out there in the community. So I will reach out to your email, but if you can shed some light when we talk about trauma-informed approaches and the fact that we may be able to have only one encounter with these persons that we're serving. What has been the optimal strategies to be able to implement effective drug overdose treatments? And do you have any suggestions in terms of maybe certain assessments that we can do that are comprehensive in the event that we don't see this person again? Not only do we treat them, but we also assess their needs and then go from there. Thank you.
Wow. So that's hefty work. Dr. Washington, I'm really, really glad you're doing it. But you got to promise not to call me Mrs. Meyerson because that's my mother. So, and as I told Miguel, the only one who calls me Dr. Meyerson is my wife. I will never do that. So Beth is fine. So, it's interesting when we're talking about trauma, it's really, it's what systems do to people. So let me give you an example. It's setting up that safe space that you're trying to do right now with your mobile van, with your mobile unit, setting the safe space with people with lived experience and sending those signals is super important. Creating that safe space, super important so that people can decide what they need. Having kind of a reporting function. So I don't know about what you're all seeing in your state, but in Arizona and parts of Arizona, people were getting arrested when they left the methadone clinic by local cops because of driving while under the influence, which of course, is a total misunderstanding of a full opioid agonist. And so, we had to stop that immediately. And so it's really just by virtue of having the community know we can say something and then a barrier can be worked on and cleared away. Not that we have to worry, do all the labor, but that others who have the privilege, like I'm throwing around the doctor of medicine all the time. And that is how you can push doors open to do these things with the police department. And so it's really kind of creating the space, the safe space, and that will come from the people around you in your program saying, what would be that first thing? Because you're going to encounter a person maybe just once. And so what would at least make the memory that that's a safe space? Because you can't do everything at once. And then having people really just know that you're always there to report to. So another example of trauma created at the clinic is If I have sexual history of violence, sexual history, and that's traumatizing, the fact that somebody's got to watch me pee is a problem. And so this is another example of kind of, oh, that's a practice that systems got to stop. And so it's really kind of learning from the people who are with us that we're working with, what is traumatizing in your world right now, just to try to get to something. I'm worried my kids are going to be taken away. And so I'm not going to go to treatment because somebody's going to report me because I just happen to be pregnant with maybe my second kid. But I know they're going to take my kids away because someone's going to report me if they don't like how I'm doing this. And so, these are kind of real and very unsettling scenarios that create trauma. I wish I had an answer and a cookbook for you to say, oh, this worked. I can only identify the things that people have told us in Arizona that create this undercurrent of just continued lack of safety and recreation of traumatizing environments. And that's what we're trying to kind of address. I hope this was helpful, and I'd be happy to keep chatting with you.
Absolutely was. Thank you so much. And I'll send you an email. Thank you.
Thank you, Dr. Washington, for your question. I believe we have two. We have one from Corey and possibly one from John. Does anybody have a preference of who would like to ask their question first?
I'm happy to jump in there. I didn't have the space for this entire meeting today, so I thought, and then I was absolutely captured by the presentation. So thank you so much, Beth, for this. A couple of things I wanted to just kind of enjoy with the folks on the call. I appreciated the emphasis around interdisciplinarity and moving toward, I would say, transdisciplinarity, and manifest and evident in the approach that you've taken. And I love the framing of these folks create a microculture of creativity. The other piece that was so powerful to me is what I describe and borrow the language from the STS discipline and Bruno Latour's actor network theory, but this notion of assemblages that we don't pay enough attention to, I think, in implementation, where you talked about that their preferred methadone and BUP, I can't pronounce that well, are socially preferred differently by different folks. And I just appreciate it, right, that this notion of how we think about all of the pieces that go into implementation, including the pills themselves, that these objects potentially have an agency that influences how they are, how adoption happens or how uptake happens. And so that was something that was really exciting for me. The two questions I maybe want to hear you talk a bit about is in the practice-based research network, if you could give any bit of insight about how relationships with clinicians and their connection to science, how that looks, and how welcomed was it? And did you have to kind of build any strategies or approaches in that space? And then also, I loved this idea of patient-centered care being intimately connected to the well-being of staff. Amazing, right? I love that perspective, and maybe a little bit just to understand how we might think about patient retention and engagement, especially when they may be dealing with barriers that keep them from care and keep them from engaging in that way. And how do you think about that in this work?
Okay, I don't know where you're located, but I got to find my way to you so I can just sit and talk and listen, and like we can throw spitballs around, because I just love this whole assemblages and the agency. And we are singing from the same song sheet, but you just gave me you like opened this whole other window, which made me think in a different way. And thank you for that. So I just love that. So first, on the practice-based research network, we have a praxis together, which is a learning, everybody knows this, you do, and you learn, you reflect, but it's hard work. And it is, things work and things don't work. And I mentioned the COVID study that we discussed. Now, the patient study was conducted first, people on buprenorphine and methadone. That was conducted first, and we all listened to that study findings, and everybody, a lot of the DPREB members actually did the work, because, every one of the interviewers was a person with lived experience. So it wasn't Beth going out there. And so, and English and Spanish and so on, so we could talk about what we found and what was important. That seemed to go well. What did not go well, which told us we kind of tripped into the praxis, was when we discussed the implementation by providers. Because of the socialization of our dear colleagues who are providers, they were all doctors and they were raised to believe they're all right, like all the fucking time. Sorry, all the time. And our people who are in their care, we don't have any direct relationships, although we always investigate how you feeling about this, blah, blah, blah. If you join the DPRAB, you got to know who's on it and so on, because it could be risky for somebody. But that whole hierarchicalization of the relationship happens and people shut down. And that's what we witnessed. And so we talked a lot about that as a DPRAB, which is how we developed the helical structure. But we also decided at that point to identify indicators of structural indicators of our enactment of community-based participatory action research, and how we set the space for safety and determine that ahead of time, and just continuously ask how that's going. So I would say our providers that are in the group, and we have our state opioid treatment authority, which for those of you new to this space, the SOTA, S-O-A-T, there's SOTA, there's one in every state. That is the singular regulator for all of medication for opioid use disorder in the state. And ours is an awesome kick-ass social worker, and Kate is her name, and she is in there. And so I think her power somehow set some of the dynamics okay. Whereas before she joined, we were really kind of, trying to find that space. But actually, the more we all travel together, and there are new people that come in and people who change jobs and leave and all of that. But, the 25 to 30 people, which is how we kind of work, seems to, we've kind of found this way of talking together. Even down to when we were discussing policy things, like the next thing on our agenda is a state standing order for syringes. And so, these kinds of things, or the adoption of the final rule in Arizona and the rate, we need to work on the rates for take home versus dosing at the window, or there's an immediate financial disincentive. So I would say my answer is not very simple, but I would say we really are learning together, and I see real effort. But honestly, the people who joined the DPRAB from the provider side, they're already harm reductionists. They already bought into the idea, and they want us to empower them to help make change. But it is those things, when things kind of get a little harder, and the critique of the group is on something important, we just have to constantly watch that process. And that's where I love having the two co-leaders, Arlene Mahoney and Christine Arredondo, together determining what should happen. And that makes it better. I hope that answered your question on the engagement scale. I know there was another piece of the question I need to answer and I forgot. I'm sorry.
About retention and engagement for folks who experience the most disadvantages in staying retained or engaged, and how
in this process. Yeah. So we pay people to be part of the DPRAB. They are a vendor of this lab. So one of the things that I talk about in another, and I think we have it on the YouTube channel, you might see kind of the praxis of engagement is a thing we all did as a medical grand rounds. We really believe that any engagement should be additive more than to a study or a purpose. So the people become a research consultant to my lab that goes right on their resume, and they're paid hourly. And the DPRAB determines every year what that pay rate is. Some people can't, and that comes out of my research fund. And some people can't accept it because of their role in government or their role in treatment or whatever. And then how we meet is a tough one when you're, for instance, a couple of colleagues who had really unstable housing, and therefore they had unstable internet. And so we had to work to figure out what the best way was for them to participate while not losing their housing for the night. And so, I mean, it really means you're creating this organic structure that suits the people in it at that time. But I still think we have a ton of work to do. So we have these kind of hub and spoke things where the DPRAB's a hub for sure. And our networks will often reach out to Drug User Union in Phoenix or in Cochise in a rural area, Yuma, whatever, and get some feedback. But it's not perfect. It's really not perfect yet.
So much more to explore, and I'm reaching out. My email will be right now.
We gotta get together. I know
Dr. Chantal's.
Thank you for your question, Corey. John, I believe you had a question that was
Yeah,
next.
great. This is really super great. I really found it very interesting. And taking everything in, we're talking about adherence and stuff like that. Everything else. I'm kind of curious. When you have a certain amount of people in your group and you're talking about safe space and the police and homelessness and this and the other thing, do you give them some sort of like an ID card that if they do get picked up by the police or they sort of how because sometimes people just drop out of studies and research like this and then they get lost. So like do you give them some sort of like ID card? So if they walk into my space and I see this card, I can contact you and say, listen, this person's here with us. He's being taken care of, and try to revert him back to your study. I mean, how do this safe space? How do we keep him safe in that way?
I love all of that. So the DPRAB is advising the lab itself. They're like my board of directors.
Okay.
So they run a lot of studies with me, but they're all linked in their communities. And to your point of safety, about 3 years ago during COVID, when we were doing the studies together and people were out in the field, the DPRAB wanted a business card for safety from harassment, mostly with drug paraphernalia or otherwise. And so we printed up member, Drug Policy Research and Advocacy Board, University of Arizona, and that helped kind of keep them safe from harassment, but not in the way that you're saying, John, where, Beth needs help and she's suddenly linked in finally to a system and she's kind of been absent for a while. And they know kind of how to hook her in. That wouldn't be to us. That would be probably to our partners in the Drug Policy Research and Advocacy Board, the rural and the urban harm reduction and treatment organizations and so on. The folks in the study, it's funny, we've had solid retention in our studies.
That's great.
This one particularly, which is shocking to me because it only pays like $20 for 10 minutes of a survey, but people do it. I'm not sure how it'll work in the trial when we've got every 11 weeks, because that's a long time and you kind of forget. And even though somebody's texting you and might say, hey, however way you decide to be contacted, whatever. But I mean, I think those things are very real. And study retention is, we haven't had any dropouts yet, which is quite surprising. Because of course that means people are actually staying in treatment, because once Beth drops out of the clinic, she's no longer eligible for the study. We're actually studying that. We ask a few questions about it. They get paid for that last survey, but definitely, we're studying how MPACT if they're experiencing MPACT. But so far, not as far as the people who are eligible for the study, we have had nobody leave it. But I think you're raising kind of really important questions that are more humanity oriented, which is, we spent a lot of time trying to contact people for research purposes, and do we actually watch out for them as humans in a network of community? And I think that's a whole other question.
Actually, I think it's kind of great. It speaks to a lot that what you're doing must really be working, and they love you for doing it because they're staying there with you. You know what I mean? Because a lot of times I've heard it and I've seen it happen where people just say, you know what, I'm just tired of this. I don't feel like getting up in the morning. And then you lose them in the study and you're trying to find out where they are and they're just not getting back to you anymore. So to be able to keep these people and keep them retained and adhere to what you're doing, I think is fantastic.
Thank you, John, for your question, and everybody else as well who's asked a question and brought in their unique perspective. I know this is a pretty rich discussion for this presentation. Do we have any other additional questions?
I have a quick question, I think, kind of more of a grantsmanship question, but I was curious if the pilot trial or the pilot and then the full trial, is that part of the same grant application, or did one come first and then the other?
This is the nice thing about these R6133s, which, by the way, I did not know, Katie, what it was until we applied. So you've got these small R's, R being research grant, and you've got, and I know you know this, but just for the group, everybody on the side. So that's the R03s, the 21s, 34s. They're 1-2 years, blah, blah, a little bit of cash to do some preliminary concepts and stuff. Okay, then you get the large R's that are really much, the ones. That's what we know about. Well, here's what's nice about the 6133. It's a small R married to a large R, and you don't have to go out for competition between them. You just have to meet your milestones. And during this crazy period that Stephen was mentioning, that we're in right now, it's a good thing, because in my notice of award, it says we'll transition if milestones are met, and we've met our milestones. So there's nobody who could say to us without breaching a contract through the notice of award as a contract that we haven't met those things. So what's nice about the 6133 is that we actually did have preliminary data, which was the traumatology, the trauma study, quick study among our OTP staff in Arizona, and then the stuff we did in COVID, but we didn't have to have that. We just did. And it's a good thing, because the reviewers were, as I say, they say for the HEAL, they're like high risk, high reward, but they do not mean it. And so, we really wanted to bring data to say, we think we're onto something. We really do think we're onto something. Look at this. And so I would say for you, as you think about kind of your options and what you want to build forth, that 61 leaves you 1 to 2 years. You can just use a 1-year 61 to do kind of the refinement of something, an alpha testing of something, or a preliminary testing of something. And then the big part, the 33, is really trial. Does that answer your question, Kate?
Yeah, that's really cool. I didn't know about that, so thank you for explaining. Very
And
cool.
you have to, here's the other weird part about it, is you'll have to educate your sponsored projects about it. Your Ames page has to be both, and your entire 12 pages have to be both. So, because, and you don't want it to be so different, they'll know your 61 is going to lead into your 33. So they know, certainly we were doing a pilot, and then the 33 is the trial. So those are different methodologies, different power analyses, different recruitment approaches, all of that, oversight board, stuff like that. But the science of the 61 does inform, for instance, power and effect size, et cetera, for the 33. You just have to, you're making that case essentially. So we've written the 33 already, and it was in with our 61. And so when we submit it, our update for the 33 is due like June 15th, I want to say. So it is literally the 33 updated with our science so that it's clear of what we're doing. And I'm happy to share ours. So if anybody wants it, they can have it.
Thanks for your question, Katie. Any other questions at this time? You can feel free to unmute yourselves and ask your question, or even enter it in the chat. We also welcome comments and praises for today's presentation.
I feel the love already. It's been great.
Well, it doesn't seem like we have additional questions, but Beth, I know you dropped your email in the chat. Can folks reach out to you if they have any other questions afterwards?
Absolutely. And the last slide of my presentation, which is also on what Miguel will post, has that whole QR code to the lab and all that stuff.
Appreciate that. Thank you. Yes, and those slides will be available shortly after. So feel free to check that out and share those in case anybody wasn't able to make it to today's call. But for everybody that did join today, thank you for taking the time to listen to our presenter today. It was a really great discussion, and Beth, right on time with your prediction, in just around an hour for the entire thing.
No one should listen to me for more than a half an hour.
Well, thank you, everybody. This concludes today's presentation. We will be having another one next Tuesday, February 11th around the same time. So feel free to join us at that time as well. And I hope you all have a great rest of your day.